So we are live, we can start.
Hello and good evening. Welcome to the expert crosstalk on Empagliflozin. As we already know, the TC 2020 is memorable with the path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, cardiology and endocrinology, which would bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to EMPA-REG trial, does SGLT2 inhibitor may be considered as an important drug for HFrEF? And for this, let me introduce today's speakers. Today's speakers are Dr. G.R. Kane and Dr. Shehla Shaikh. Dr. Shehla Sajid Shaikh, she is a consultant endocrinologist at Prince Allan Hospital and Shaikh Hospital, Mumbai. She is a renowned national and international speaker at various forums and has numerous national and international publications in her career. And also, Dr. Shehla has numerous academic achievements till date, and her area of interest are childhood obesity and its prevention, thyroid disorders, osteoporosis, and structured diabetes care. I welcome Dr. Shehla Shaikh in this expert web talk.
Thanks,
Our next speaker is Dr. G.R. Kane. Thank you, ma'am. Dr. G.R. Kane is a professor and head of cardiology, D.Y. Patil Institute of Medical Sciences. And he is also a consultant cardiologist at Hinduja Hospital, Bridge Candy Hospital, Nanavati Hospitals in Mumbai. And I welcome Dr. G.R. Kane in this expert web talk. And I am handovering the session to Dr. Shehla.
Thanks, Dr. Shaikh. And nice to see you, Dr. Shehla.
Yeah. Same here, sir. Pleasure always.
Yeah.
Hi, everybody, and a very, very good evening to each and every one of you out there. I understand that lockdown is now we are in unlock phase, and I know that everybody's most probably had a long, hard day at work with managing a number of patients, number of complications. And I really appreciate the fact that in spite of the busy schedules, you have still taken out time to be with both of us today. A very, very big thank you. I also want to acknowledge Lupin and say thank you for them for all the academic endeavors and for always trying to spread knowledge. Coming to EMPA, multiple indications, multiple mechanisms. I totally agree. In the last meeting that we had between the cardios and the endos, I remember the tug of war, whether it's an endo drug or is it a cardiologist drug. But to be very honest, I think it's a drug which belongs to all of us because it is no longer only an anti-hyperglycemic drug, but it is a drug whose so-called pleiotropic benefits, I think, have actually overshadowed the anti-hyperglycemic benefits. So you have a drug which initially started with just anti-hyperglycemic benefits to a drug which has now practically encroached upon every area when you're looking at a diabetic patient. So what is our perspective per se? Huge amount of evidence, as we all know. I won't get into all that as of now, but we know a lot of evidence out there. And what are SGLT2 inhibitors exactly doing at the cellular level, at the molecular level? We all know around 180 grams of glucose is filtered every day by our kidneys. And we know that SGLT2 inhibitors basically reduce this glucose reabsorption in the proximal tubule, leading to urinary glucose excretion and osmotic diuresis, which otherwise on a routine basis is not allowed by SGLT2 and SGLT1, because SGLT2 causes 90% of the reabsorption of glucose. We know it has a huge capacity with less selectivity, and SGLT1 causes almost 10% of reabsorption because of its huge selectivity and less capacity. Having said that, what are the pharmacological properties of the available SGLT2 inhibitors that you and me are using? You and me at this point of time are most commonly using EMPA, DAPA, CANA. The starting dose of EMPA and DAPA is 10 milligrams, as we all know, but EMPA, most of us start directly from 25 milligram, and most of us are comfortable using CANA 100 milligram. Very few of us really go to CANA 300 milligram. As far as administration is concerned, EMPA and DAPA can be used with or without food, whereas CANA is given before the first meal. Again, knowledge which is very, very evident, and I won't go into the details of this. What is most important, I think, in this entire thing is the selectivity. There is a certain selectivity property of EMPA of almost 1:5,000 vis-a-vis DAPA and CANA. And the glucose excretion, this translates into a glucose excretion of 78 grams per day with EMPA, around 70 with DAPA, and around 119 grams per day with CANA. The most important thing that we need to understand, which we actually think about using. I'm sure all of you have seen this slide an n number of times, but it doesn't hurt to reiterate. We know across the spectrum, because of its mechanism of action, because it is not insulin dependent, you know that across the spectrum, whether you use it right at initiation, right at diagnosis, if you use the molecule just and alone, or you think in terms of using the molecule along with metformin, or with SUs, or with PIO, or with insulin, or even with mild renal impairment, you know that the molecule is going to work across the spectrum simply because of its mechanism of action. One of the areas which is very interesting is when you're using it along with PIO, because along with PIO, the side effects of PIO with EMPA are more or less negated. And in clinical practice, you can potentially, especially in an Asian setup, you can potentially have a combination which metformin, PIO, and your EMPA, which can act together as very, very good insulin sensitizers. What about blood pressure? As I was talking about the pleiotropic benefits, you would realize over here, again, across the spectrum, what about body weight? When you talk in terms of body weight, I was talking about pleiotropic benefits. And what you would again realize over there, one of the biggest issues that we face in our country at this point of time is diabetes. We are increasingly talking about obesity. We are talking about childhood obesity. We are talking about adult obesity. And we know as clinicians how difficult it is for our patients to lose that even 1 or 2 kgs, which apparently on paper looks so simple and so easy to do. But we know that it is not very easy to do. At the same time, we also know that when you are looking at an obese individual, for the metabolic benefits, you are initially talking in terms of a weight loss of 5 to 10%. And why are you talking about this 5 to 10%? Because that 5 to 10% weight loss translates into a reduction in the ectopic fat. This 5 to 10% weight loss results in a reduction in the bad fat, in the metabolically unhealthy fat, which then in turn translates into benefits. Those benefits would be as far as all the cardiometabolic factors go, be it diabetes, be it hypertension, be it dyslipidemia. And as an end result of this, this is going to, of course, translate into cardiovascular benefit for all your patients and potential reduction in morbidity as well as mortality. If I talk further about the pleiotropic benefits, yes, when you talk about blood pressure, again, you know that in our diabetic patients, you often see a combination of diabetes and blood pressure. And if you can use a molecule which could potentially contribute to this for reduction in blood pressure further, definitely it helps you. And across the spectrum, again, whether you're using it as monotherapy or you're using it along with the combination of metformin or PIO or SU, there is a significant reduction of blood pressure, almost to the tune, and when you're using it metformin, almost to the tune of 4.8 millimeters of mercury too, which is very, very significant reduction of blood pressure. Now, when you're talking in terms of reduction in blood pressure, is this molecule going to actually interfere with the nocturnal dip that you are seeing? What happens actually in an ABPM when you're studying patients with EMPA in type 2 diabetic patients and trying to understand what happens to patients who are on EMPA vis-a-vis when you compare them with a placebo? This was a very, very elegant 12-week study. This is a Japanese study. And in this study, it was seen at the end of 12 weeks, not only does EMPA cause a significant reduction as far as blood pressure concerned, but this is not associated with an increase in pulse rate, very, very important. And most importantly, it also mimics the normal pattern of your blood pressure, that it does not interfere with the nocturnal dip, and it simply follows that pattern which you definitely want to see in your patients. Again, if you look at the diastolic blood pressure, you would realize that even when you look at the diastolic blood pressure, this was blood pressure which was measured every 5 minutes. In this study, there was a reduction in diastolic BP also seen, which was not associated with any kind of increase in the pulse rate, which is of great clinical importance to you. What about lipids? Lipids has always been an area of, I would say, controversy where gliflozins go. But is it really an area of controversy, or is the controversy actually laid to rest now, considering the great cardiovascular benefit, considering the great renal benefit? You would realize that yes, there is an increase in LDL with the use of SGLT2 inhibitors, but this LDL is the less atherogenic LDL. This is the buoyant LDL, and this is the potential LDL, which is not going to contribute to atherosclerosis. So yes, these are molecules which do cause some increase as far as the LDL is concerned. They also contribute to some increase as far as the HDL and total cholesterol is concerned. But as I said, when you are talking about your diabetic patients, you are talking about patients who have a very, very typical dyslipidemia profile. These are patients with small dense LDL. These are patients with high triglyceride. And these patients may not be patients with very high total cholesterol levels actually. But in these patients, when molecules such as these are used, you could actually be contributing to reduction of the atherosclerosis, because these molecules could potentially reduce the atherogenicity of the LDL molecule in circulation. So if I try to put in a nutshell, what is the effect of SGLT2 inhibitors on glucose control, on body weight and systolic BP? I won't go into the details. This slide is a little crowded, but the most important message which we are trying to give across with this slide is that's a huge number of patients who have been evaluated. Really huge number of patients. If you just at a glance look at this slide, you would realize that we are talking in terms of almost 20,000 plus patients who have been evaluated with some kind of combination. Across the board, there has been a reduction as far as glycemia goes. There has been a reduction as far as body weight goes, and there has been a reduction as far as systolic blood pressure goes. So it is the writing up there on the wall which shows that yes, across the spectrum you have benefit. Benefit, yes. What about side effect profile? I think one of the biggest issues as far as SGLT2 inhibitors has always been that niggling doubt about side effects. You're always worried about it. I think the most important side effect, to be very honest, in this entire list would be genital infections. Yes, that is an issue, but with proper counseling, proper education, proper advice, I think this incidence can be reduced to a very, very significant extent. And I personally believe that when you are giving a prescription of SGLT2 inhibitor, it is very, very important that you explain to your patient regarding the potential issue of genital infections. If you look at the urinary tract infections, you would realize that there is not a very significant difference between the placebo group and the patients who are on EMPA. But if you look at the genital infections, yes, there is a significant difference. And that is something which I think we need to keep in mind at all points of time. So what about EMPA and cardiovascular outcomes in patients with diabetes at high cardiovascular risk, the EMPA-REG outcome? You've heard it an N number of times, but we will still talk about it all over again for the simple reason that today we want to put another very important point across when we talk about the EMPA-REG trial. You know all this. You know it made a difference as far as 3-point MACE was concerned, a hazard ratio of 0.8. As far as CV death was concerned, a hazard ratio of 0.6, which led to the very, very important label that it makes a difference as far as mortality goes. I think it's the only molecule in the diabetic segment which has that kind of label. Death from any cause, again, as I said, hazard ratio of 0.68, and hospitalization for heart failure, I think, is bygone. We know that it makes a difference over there. As far as renal data goes, again, very, very significant differences, whether we are talking about incident or worsening nephropathy, we're talking about progression to macroalbuminuria. And these are, mind you, areas where in spite of everything that we've done, in spite of patients being on ACE inhibitors and ARBs, we have still not been able to absolutely put the nail in the coffin. We've always had issues as far as these areas of therapy have been concerned. So yes, if you have a molecule which is going to make a difference in these areas, you definitely are interested. So patients with type 2 diabetes and high CV risk, EMPA, when EMPA was given in addition to standard of care, we are talking about a patient who already is receiving whatever is required. There was still seen reduced heart failure, hospitalization, or CV death. And this was a consistent benefit. And this was seen both in those patients with and without heart failure at baseline, which is very, very important. And why am I talking about this? What am I trying to build up on? What very, very important thing that I'm going to build up on over here is that how early were these benefits seen? When were these benefits seen? And you would realize that we need to understand that there's a very early separation actually of the cumulative incidence curves. Really early separation. Hazard ratio, mind you, stabilized as number of patients with events increased over time. And the benefit of EMPA in reducing the risk of hospitalization for heart failure, CV death, and CV death emerged within weeks. This is something very, very important because we do not see molecules having benefit within weeks, mind you. We expect molecules to benefit within months. We might sometimes expect molecules to benefit long term, but within weeks is something which is totally, totally new to look at. And how early? You would realize that the reduction in risk with EMPA versus placebo was significant, mind you, at day 17. That's really quick. Day 17 for HHF, that's really quick. Day 27 for CV death or HHF, and there was a sustained significant throughout follow-up. So it makes a difference, and this difference is sustained. And the benefit on CV death, again, mind you, was seen at day 59. So you're talking in days, you're talking in terms of days, you're no longer talking in terms of months, forget years. You're talking about molecules who are acting quick, you're talking about molecules who are showing benefit in days, and you're talking about molecules which have sustained benefit. It's not like you're seeing a benefit and then benefit sort of disappears with time. You are seeing molecules where the benefit is absolutely sustained. Huge amount of number of trials done over here. I won't get into the details of this, but what I would definitely like to put across is that there could be a number of factors which are contributing to this benefit. And that's the reason I think SGLT2 inhibitors are everybody's friend, be it cardio, be it an endo, be it nephro, because you would realize that there are, and there could of course be a lot of new pathways involved in this entire process. But as of now, definite improvement as far as hyperglycemia goes, definite reduction as far as albuminuria goes, definite influence on the weight, definitely reduction of blood pressure. We already spoke about lipids, reduction in your uric acid, and reduction of your SNS activity are some of the various factors which have been postulated to be behind the benefit with SGLT2 inhibitors are providing you. And that is the result. You would realize that, yes, whether you're looking at EMPA, you're looking at CANA, you're looking at DAPA, or you're looking at ER2, across, as I said, the only molecule which has a benefit as far as CV death is, as we all know, EMPA. As far as the hospitalization for heart failure benefit goes, it is similar across the spectrum, more or less. You would find all the molecules are giving you that kind of benefit. But as far as kidney outcome goes, again, you would have significant data as far as EMPA, CANA, and DECLARE goes. But you know that the Vertis CV did not show you similar benefits. And post the Vertis CV data, there has again been a sea change in the thought process. What are we looking at? Molecules with a class effect? Are we looking at molecules with actually just a molecular effect? We need a lot more data. We need a lot more of thought in this to really understand what exactly are we looking at when we're looking at these molecules. So what did all this result in? What did all this new data result in? Paradigm shift, a total change in thought process. Why? We all were used to talking in terms of metformin as the first line drug therapy. From the time I remember, we've been talking about metformin. Now, irrespective of HbA1c, mind you, it's a very, very important statement coming out that irrespective of the glycemic control, if you have a patient who's drug naive or on metformin, but if this patient has an ASCVD or is a high or very high cardiovascular disease risk, then you will think in terms of an SGLT2 inhibitor or a GLP-1 receptor agonist. Very, very important change as far as the paradigm of treatment of our patients of diabetes is concerned. If you look at the 2019 ESC guidelines, again, a shift in your thought that maybe you don't need to think always in terms of metformin as the first drug of choice, especially in this situation. And if you look at the 2019 ACC-AHA practical guidelines, you can consider metformin as first line of therapy if the HbA1c is more than 7. But in patients with cardiovascular disease risk factors, then you would think in terms of an SGLT2 or a GLP-1 receptor agonist. And over here, I would like to end my talk And I'm going to give it over to the cardiologist for Sir's perspective on what he thinks, what is the exact role SGLT2 inhibitors play in a cardiologist's mind. Thank you very, very much for your absolute patient listening. Dr. Kane, over to you. It's all yours.
Thanks for an excellent perspective on empagliflozin. In fact, you have covered almost all the gliflozins, and I basically have to talk a little bit about being a cardiologist. So welcome everybody, whoever is attending this, and thanks to Lupin for giving us an opportunity to participate in this webinar. My job is to actually talk about the latest thing about empagliflozin and about the gliflozins in heart failure. Dr. Shehla already covered up that empagliflozin, how it is effective in diabetic, and more than that, it is effective in reducing the cardiovascular mortality. Let me admit something right at the beginning. There are very few things in cardiology which reduce mortality. Like, for example, our angioplasty or bypass surgery, more often than not, they reduce the patient's symptomatology. They make the patient feel better. But mortality reduction is a very, very rare event in most of the conditions in life, for that matter, and in cardiology specifically. So here is a drug which has a significant reduction in mortality. EMPA-REG outcome was so significant that it is an eye-opener for all of us. And how it all started, I would always like to go back a little bit into the history. Because it all started, we always look at, if you have an anti-diabetic drug, you want to reduce sugar. If you have an anti-arrhythmic drug, you want to reduce arrhythmia. But it was in 2008 that it was realized that you may have a very well reduction in sugar with a diabetic drug, but you may have a higher mortality with cardiovascular events. So what is the use of that? Because most of the diabetics die because of finally cardiovascular. And that is when in 2008, the controversy over rosiglitazone, the FDA came out that every anti-diabetic drug has to show a 2-year safety data as far as cardiovascular events are concerned. And that is how all these newer aspects of anti-diabetic drugs are coming. Same with other drugs, but mainly anti-diabetic drugs. It's compulsory to show a 2-year safety data. Now, we have looked into, and Dr. Shehla has nicely put up that empagliflozin, if it is given to diabetics, which was done in EMPA-REG trial, they found that there was, with atherosclerotic cardiovascular disease, there was a significant reduction in cardiovascular death, mortality. And it was also observed that patients were, number of patients with heart failure, few patients were there, their admissions to the hospital were reduced, and the incidence of heart failure of such patients with atherosclerotic cardiovascular disease was reduced. So this was a byproduct observation of an EMPA-REG trial, which was basically looking at cardiovascular mortality and morbidity in patients with diabetic being treated with empagliflozin. And that is how these newer trials have come, which are looking at gliflozins to reduce heart failure, morbidity and mortality, and also to prevent renal dysfunction or progression of renal function. So this is one of the very important trials that is published, is presented in the European Society of Cardiology 2020 August meeting, just 2 months back, and it's been published in the NEJM. And we will discuss a little bit about that, how EMPA-REG can help prevent heart failure mortality as well as heart failure hospitalization. So this was presented by Milton Packer, who is an authority on gliflozins. And what was just a small background in this trial, EMPEROR reduced trial. In fact, this EMPA-REG has been studied in EMPEROR reduced and EMPEROR preserved. So both in preserved ejection fraction and reduced ejection fraction. But I'm going to discuss only reduced ejection fraction for today. The authors say that they evaluated the effects of empagliflozin in a broad population of patients with chronic heart failure and a reduced ejection fraction, with or without diabetes. Once it was realized that it helps heart failure, whether you have diabetes or not, heart failure becomes the primary entry point for this study. That was enriched for patients with more severe LV dysfunction and marked increase in natriuretic peptides. There is another study, dapagliflozin, where the LV ejection fraction was slightly better off and the natriuretic peptides were not markedly raised. So this is the real crux of this study, which took patients with lower ejection fraction, markedly raised natriuretic peptides. So eligible patients were randomized to a double blind 1:1 ratio to EMPA-10 or placebo in addition to the usual therapy. These patients were fully on the standard guideline directed medical therapy for heart failure, and only after that they were taken up into this study. And what was the trial? The end result or the endpoints were very specific. The primary endpoint was a composite of CV death or heart failure hospitalization, which is a very, very specific endpoint. And the secondary endpoints were hierarchical. The first was total or recurrent heart failure hospitalization. And the second was leading to the renal dysfunction, the slope of decline in GFR over time. When you study renal endpoints in patients with diabetic or any study, you look at how much you can prevent the deterioration of renal function, and that is judged by fall in the rise in creatinine, or fall in glomerular filtration rate, or time to dialysis, or time to transplant. These are the endpoints which are used for judging the renal dysfunction whenever you want to study the effect of a drug on preventing or deterioration of renal function. So these were the endpoints. Inclusion criteria: all above 18 years, chronic heart failure, class 2, 3, 4, LVEF less than 40%, heart failure hospitalization within 12 months, and they gave a specific anti-proBNP criteria, 600. You can see this here, and that is required because you have a definite identity of heart failure in these patients, because otherwise, heart failure is a broad entity where sometimes the diagnosis itself is difficult. So if you have symptoms of heart failure like breathlessness, fatigue, and you have raised this, then you have a more specific patient, and EF is reduced. So if you have atrial fibrillation, then these markers have to be double in those particular EFs, ejection fractions. So exclusion criteria. Now, this study did not include patients with acute coronary syndromes within 90 days or TIAs, patients for heart transplant, patient of infiltrative or other cardiomyopathies, severe valvular heart disease were not taken up in this. Acute decompensated heart failure was not studied. So these are chronic stable patients, which is the crux of our patients who we have to treat for survival for a longer time, keep them symptom free, and if possible, prolong their life and prevent death. So this is the exclusion criteria. The other salient features was Asians were about 80%. NYHA class was 75%. It was class 2. Mean ejection fraction was lower than the other study, which was on dapagliflozin. It was 27%. 50% had diabetes, 50% were non-diabetics. eGFR was lower in this study as compared to any other study done on heart failure. And most of these patients, 90% of them were on beta blockers, 70% were on AC inhibitors or ARBs, and nearly 20% were on ARNI, and 70% were on mineralocorticoids. So they were well controlled or fully given the guideline directed medical therapy, and even 30% of them were on ICD, and about 12% were on CRT. So all other things were already done. On top of that, you have to show that whether this drug can benefit them beyond this, because you can't go beyond this is transplant. So 7,000 odd patients were screened, 3,730 were randomized, 1863 to empagliflozin 10 milligram, and 1867 to matching placebo. Median follow-up was done over a period of 16 months, and the final vital status was seen in 99% of the patients. It was recorded. Now, just to see the baseline characteristics, just to compare EMPA reduced to the DAPA heart failure, which is the other major study on heart failure. You can see this, which is highlighted. This is a complex slide, but you can just concentrate on the red marked things. The ejection fraction was lower in this trial. Anti-proBNP was much higher in this trial. Glomerular filtration rate is lower in this trial as compared to DAPA. So these were more sicker patients. These were more grossly in heart failure patients who were not very well controlled, despite the adequate guideline directed medical therapy that we otherwise start before this drug came into existence. So that is the importance of these baseline characteristics. And if you see the results over a period of 16 months, you will find that the time to cardiovascular death or the first hospitalization for heart failure, which was the primary endpoint, there was a significant 25% relative risk reduction which with a p-value of less than 0.0001, which is highly significant with a hazard ratio of 75. So you rarely get this type of results with any drug or any therapy for that matter in cardiology. It's not very easy. So that is the importance of this drug, that it shows a remarkable benefit over and above the guideline directed. You can imagine. So you have already finished with the guideline directed therapy, and now you are coming to a saturation point, and there you have a benefit after that also by starting this drug, which is the real importance according to me of this magical drug, I would say, which is now available to us to treat patients with or without diabetes, with heart failure and with renal dysfunction, and a significant benefit. So this was the individual component benefit. And you can see that the primary endpoint in different subgroups, the endpoints were similar, whether you are diabetic, non-diabetic, you are elderly or less than 65, male, female, white or other. Most of the groups you can find that the results were entirely similar on empagliflozin. There were not much different. So it is on a broad spectrum. This drug works very well on reducing the primary endpoint of cardiovascular death and or first hospitalization for heart failure in patients with heart failure with reduced ejection fraction. Majority of them had ejection fraction below 30%. And this is the secondary endpoint. We said it is hierarchical secondary endpoint. So the first admission or a recurrent admission after the first one, there also there was a 30% relative risk reduction, which is again significant 0.0003, hazard ratio of 0.70, which gives you a relative risk reduction of 30%. So significant secondary endpoint reduction. And if you see with the renal dysfunction, there was again a significant benefit on the renal endpoints, and you find that the reduction in reduction in the glomerular filtration rate or EGFR was much slowed down because of empagliflozin as compared to placebo, over and above all the guideline directed. I'm repeatedly saying over and above because we are bound to give the guideline directed therapy which is existing first before we come to the newer drugs. Because if you start the newer drugs without evidence, then you will never know whether the patient would have benefited with the standard therapy that is available. So the initial trial has to be done on fully guideline directed medical therapy first, and then you try this drug and then you find benefit. Then we may change our paradigm that whether this drug should be started after those drugs or whether this drug comes very early in the process of heart failure treatment. So that is what is to be determined. But the benefit is remarkable. You can find significant benefit on all endpoints: cardiovascular death, mortality, heart failure hospitalization, and deterioration of renal function. That is a significant benefit which you can see. So you can see here the 50% relative risk reduction in renal deterioration on patients with empagliflozin in this trial. So that's why the hazard ratio is 0.50. And this is the benefit you can see with this serious heart failure and kidney events, that you can find both cardiovascular death and hospitalization for heart failure or the composite renal points. There is significant benefit, 25% relative risk reduction on the death and hospitalization, and 50% relative risk reduction on composite renal endpoint, which are very significant. Let me tell you, very few drugs will give you something like this. So this is something which is very heartening and good for our patients and good for us. So this is what the same thing, 25% relative risk reduction on primary endpoint and secondary endpoints, 30% for heart failure hospitalization, and really 50% for renal endpoints. So, and even in the Kansas cardiomyopathy score clinical summary, there was significant benefit. So there was no much difference in all-cause mortality, but the cardiovascular mortality, hospitalization, which is the primary endpoint in heart failure, you can rarely get those endpoints. Forget about all-cause mortality. So that is the importance of this drug. Looking at when you give heart failure drugs, let me tell you, if you give ACE inhibitors, ARBs, diuretics, they have quite a few of side effects. They can cause volume depletion, sodium deficiency, hyperkalemia. But with this drug, if you see the adverse events, they are very less. Volume depletion, you can see hypotension, hypoglycemia, which is a diabetic drug. They are very notorious to cause ketoacidosis and hypoglycemia. Very minimal in this. Cardiac disorders itself was no much difference. Worsening renal function was better with this drug. Cardiac dysfunction was better improved with this drug. So these are the significant benefits as compared to all the other drugs which are used in heart failure, because they do have side effect of volume depletion, hypotension, hyponatremia, hyperkalemia. One of the few problems with this drug is obviously urinary tract infections and genital infections, but they are also remarkably reduced if you are aware of this problem, if you make your patients aware of this, and you tell them the precautions for hygiene, and these are remarkably reduced. So I'm sure as time passes, these drugs will still come much higher up in our line of treatment because of heart failure, because the benefits are remarkable. And this is just a comparison between DAPA heart failure and EMPA-REG. Both the drugs have shown some significant benefits in heart failure and in patients with cardiovascular baseline disease. So these are both important drugs, and empagliflozin is highly effective. So in conclusion, ladies and gentlemen, in patients with chronic heart failure and reduced ejection fraction, EMPA-REG trial achieved all three endpoints pre-specified as key outcomes by hierarchical testing, each with a p-value which is less than 0.001. Very highly significant benefit. The 25% decrease in the risk of composite cardiovascular death and heart failure hospitalization observed in the EMPA-REG was identical to that seen in DAPA heart failure. So both these drugs have shown remarkable similar benefit, but this study included more sicker patients with more severely reduced ejection fraction, more renal dysfunction. So that is the importance of this trial, that even with much higher rise of anti-pro-BNP, so these were more severely affected patients, and remarkable benefit is shown by EMPA-REG. So we believe that the results of EMPA-REG should be sufficient to establish SGLT2 inhibitors as a new standard of care for patients with heart failure and reduced ejection fraction. Now, how come this drug is like a wonder drug? You know, there are people are still studying, the authorities are still studying what are the different mechanisms how this drug is benefiting. Initially, it was thought that sugar reduction was causing it. We soon realized that sugar reduction takes few months, but few weeks to months. But the benefit cardiovascular come much faster, much rapid. So then they thought natriuresis is causing, but it does not cause so much of hyponatremia. So the volume depletion is mainly interstitial edema is reduced, and the extracellular volume is not reduced. So you don't have hypovolemia, what is seen with normal diuretics. So that is a tremendous advantage with that. And there is preload reduction, afterload reduction, LV wall stress reduction, and the cardiorenal physiology is somehow remarkably altered by this drug in a beneficial way, that you don't have much of the side effect which other drugs like ACE inhibitors, diuretics, and beta blockers have, which this drug doesn't seem to have, with all the possible beneficial effects that those drugs have, and some other added mechanisms. And the mechanisms are still being discovered by the authorities, why this drug is so different from others with so much of benefit with very little side effects. That's a wonderful thing about this drug, that I would like to say, that the usefulness of this drug. So EMPA-REG trial has major implications for our clinical practice. The EMPA-REG trial with empagliflozin will have a major impact on the management of patients with chronic heart failure and a reduced ejection fraction, whether or not they have diabetes. That's the first point. SGLT2 inhibitors have clinically important benefits. They can be given only once daily. They require no dose adjustment, and they are very well tolerated as compared to majority of the other drugs which we use in cardiovascular system. And there is now a compelling evidence that SGLT2 inhibitors should now be added to the currently recommended treatment of this disease. And the currently recommended is ARNI, or that is sacubitril valsartan. In most of the Western countries, ARNI or the sacubitril valsartan has replaced ACE inhibitors. In our country, we still use ACE inhibitors as the first line because of the cost and the other issues. But Western countries, I learn, and I've participated in some of the other seminars, UK and European and Western countries, they are now shifting as to sacubitril valsartan as the first line, and they are eliminating ACE inhibitors because there is definite benefit shown with that drug. Beta blockers remain a cornerstone, then spironolactone, and now this is the fourth pillar, which is empagliflozin. The mechanisms are much different from all the other three drugs. So a combination of these four drugs would be an ideal combination to prolong life, to prevent hospitalization, and to keep the patient's well-being to a longer duration, preserve the renal function for a much longer time so they don't require dialysis, they don't go into fall in GFR, and they don't go into albuminuria, which is gradually progressive. So all those are reduced or delayed. So that is the benefit of this drug, ladies and gentlemen. So we are having a very, very important drug, and we need to use this more often. And we will be learning about this as time passes. What is the ideal place of this drug, whether it comes first line, second line, or in combination with other drugs. Thank you very much for your attention. Thank you very much. How do I come out of this?
I said, Dr. Kane, I hope we haven't done what the last slide showed.
No. That was for people who I feel so. I don't have to say
It's a lovely slide.
That's just to wake up, sometimes if you do that.
I know.
How do I unshare my screen? Can I put my slides off?
You unshared already, Dr. Kane.
Yeah, but I can't see you all.
Speaker view.
Okay, now.
Gallery view. Yeah.
Okay, yeah. So I think, Shehla, we have done a fairly good job at whatever we were supposed to do, and I don't know whether there are any questions or what the Lupin Dr. Shaikh, no? Dr. Shaikh, are you here?
Dr. Shaikh, yeah, we have a question, sir.
Yeah. Sure.
Okay. We have a question. The question is there any clinical trial with specific Indian patient with EMPA?
I am not aware of a specific trial with EMPA on Indian patients, but there were a large number of almost 20% of Indian patients in the EMPA-REG trial, and even in the heart failure trial on EMPA reduced trial. There were a lot of Asian patients, and India was one of the major sites. Are you aware of any? I don't know whether Shehla is aware of any.
No. There's no exclusive trial which is done only in Indian patients.
Yeah, that's what I think so. Yeah. But there were lots of Indian patients in that trial, so it is represented. I have shown that also slide. Almost 18% were Asians, and there were a large number of Indian in that.
Yeah. Okay. The second question is EMPA or DAPA. Which one you prefer for better results in heart failure patients?
Okay, I think that question is to me. If you ask me, frankly, I feel both the drugs have shown remarkable benefit. There are slight differences as far as trials go. The trial, if you see the trial, EMPA was done after DAPA. So EMPA has chosen patients with lower ejection fraction, with more higher NT-proBNPs, with more renal dysfunction. eGFR was lesser in this trial. So the benefits are much more. So it looks like EMPA shows much more benefit. But I'm sure both are showing equal. I would say they are equally beneficial. I would not be able to differentiate between the two, because you can't compare apples to oranges. If you really want to compare, you will have to compare EMPA and DAPA in the same patient population, which has not been done. So you can't take two separate trials and then try to compare them. That is not a fair this thing. And I don't think that is required, because both have shown very, very good results. That would be my answer.
Okay. Sir, there is a last question. Can we prescribe SGLT2 inhibitor in patients without established CVD or having multiple CV risk factors?
Absolutely. Because what happened was that, see, the EMPA-REG trial, I think Shehla also can join in this. EMPA-REG trial, they took 100% atherosclerotic cardiovascular disease patients. Whereas the CANA study and the DAPA study, there were patients with risk factors. So there was both primary prevention as well as secondary prevention type of a thing. And in both these groups, they showed the benefit. The secondary prevention, people with established atherosclerotic cardiovascular disease, the benefit was much more remarkable. But in patients with risk factors, also the benefit was significant. What do you say, Dr. Shehla?
Totally agree with you, Dr. Kane. Sir, totally agree. That what you put it absolutely perfectly, that the benefit is remarkable as a secondary prevention, but the benefit is also seen with primary prevention. There is no question in that.
Okay, fine. Anyway, ma'am, there is no more question. So with your permission, can you stop the session? Yeah.
If sir gives permission, we can stop the session.
Yeah. Sir, anything to say?
No, I think we should have this drug is remarkable, and
Yes.
Sure, we are still learning the benefits of this drug, and probably I'm more impressed with renal dysfunction prevention. That is one of the major worries for us, because most of the drugs which we use in heart failure, they cause gradually progressive renal dysfunction. So if this drug is found to be protecting the kidney somehow, then I would have this drug much higher on the cards. So I may start this with people who are asymptomatic heart failure, or class 1 or class 2. This where we start AC inhibitors, which are the drugs and beta blockers are used in class 1, where you don't have symptoms of heart failure, but at you have risk factors, or you have hypertension, diabetes. So I would say this drug will come much higher as time passes. It will come as a preventive and not only as a therapeutic like RBP or some other drugs which we have been trying.
Yes.
So that would
Thank
be my
you.
end. Do you have anything to say, Dr. Shehla?
Dr. Shehla? Yeah.
Parting remark.
I think there's a still, I mean, the only caveat I have over here is that I totally agree, a drug with remarkable benefits, but we also need to keep a little bit of the side effect profile in mind. Sometimes we need to use it in the right patient, right time. For example, a patient is infection, please withdraw the drug. Please don't use it in your type 1 diabetic patients. Keep an index of suspicion for euglycemic decay also. I think we need to, also, I mean, I understand we are very enthusiastic about the drug, but we increasingly also see situations like this where, you may not, I mean, you may end up using it with the wrong kind of indication, which is increasingly happening. So I think we are still on the, I personally feel we're still on the learning curve of the drug. An excellent molecule, there's no questioning that whatsoever. But we still need to understand how exactly is this molecule working. I think there's still a lot to learn about the pathogen. I mean, the pharmacodynamics and pharmacokinetic molecule. We have a lot of obvious data out there, but still I feel there's some data which still needs to sort of come out. I'm not talking about clinical data. I'm talking about actually biochemical data, maybe, or data from the labs as to where exactly is this molecule working.
Yes.
I think you put it very well. Those are very good points, which we must mention to our colleagues who are going to use this drug, that they need to take some precautions are required. It's not that you can use it in left, right, and center, but you should take precautions. It's a wonderful drug with the proper precautions. Yeah, like you put right here. Yeah. So, Shaikh, are we through?
So, yeah. Thank you, Dr. Kane and Dr. Shaikh, for your wonderful presentation and sharing your experience. And definitely, on behalf of Lupin, we thank you both, and we'll see you in the future meetings, sir. Okay. Thank you.
Thank you so much.
Thank you,
Shehla.
Thank you,
Nice
sir.
time.
Thank you, sir.
Bye-bye.
Thank you.
Bye.
Thanks, everybody. Log in. Have a nice evening. Bye.
Bye.